First item, hello, everyone. I think I'll call the meeting to order. The first item is approval of the minutes. Do I have a motion to approve?
So moved.
Second.
Is there a second?
Second.
Okay, all those in favor?
Aye.
Aye.
Okay, thank you.
Any
I'm
opposed?
abstaining. I
Okay.
wasn't at the meeting.
Ken, are you okay? I didn't see your hand up.
I said I'm abstaining because I wasn't at the meeting.
Okay, thank you. I have everybody. Thanks.
Okay, great. Next, I'll turn it to Michelle for the executive report.
And we'll have one little change before executive report. For the July board meeting, we had removed public comment from the agenda because we had that shortened meeting and it did not get put back on. So that was an oversight on my part. And we do have someone signed up for public comment today. So we're going to switch to public comment. And Cynthia, I'll turn it over to you. I think you know who signed up, and make
Yes.
sure they're here and they can speak.
David Stewart from AHEC Western, and I believe he's on the line. Just double check.
There he is. Okay, we can see
Okay.
him. Go ahead, David.
Okay.
Yeah, well, I was thinking public comment came at the end, but that's okay. I'm speaking on behalf of my program and what happened recently with the budget cuts. And I understand we are at the mercy of the feds, but I want to acknowledge what a huge setback that's going to be for the most vulnerable, least served people in Maryland. I feel like what all of the connector programs have done is reach those people and has built an enormous amount of trust across many different communities that are underserved. And I know how crippling the budget going forward is going to be to my program, and I'm assuming it's the same for all the programs. But I just want to say that we're going to be pretty crippled, not set back. It's going to be really hard to get through this open enrollment. And I just feel like I want to also say that it won't just pick up where we left off. I mean, I'm assuming FY27, maybe the program ramps up again. But I feel like there's going to be, not intentional, but I know that many people in the community, they feel sort of betrayed already by just the general what's going on in the world. If you look at the immigrant community, for example, my Spanish language appointments used to be in Washington County, used to be 9-8% and 4 or 5% across the whole region, and now it's down to less than 2%. So there's a lot going on out there for folks who are very vulnerable and underserved. And I feel like this is going to break trust with those communities. No controlling it, not the intention, but I feel like the impact will be that. And I feel like if we start this program up again, it's going to be a heavy lift, because I feel like it's going to take a little bit more than just it won't just turn back on again. There's going to be a lot of developing that's going to have to happen. So that's really all I wanted to say. It is the world we're in, but I just kind of wanted to speak to the impact that I see happening. That's all.
Thank you, David. Thank you for that comment. And I'll move into my executive update, which does cover exactly what David's talking about. So today on the agenda, really one of the most difficult things on the agenda today is, it's a good thing, partially good, partially not good, is moving ahead with the extension of the fiscal year 25 connector entity grant. As you know, the board approved in April a 3-month continuation of the grant funding under the fiscal year 25 grant proposal. Because under a change of federal requirements now, things had to go to CMS for approval for funding. And the idea back in April was we would extend it for 3 months so that it would take us through the federal funding period, and we would then get approval from CMS for additional funding. That approval from CMS has not come. So we have no funding for the federal work that we do, which is half of the budget. Half is funded with state funds and half is funded with Medicaid funds to support the Medicaid work that we do. So sadly, as you know, because it's in your packet, and we met with the connector entities last week to inform them that we would be coming to the board with a continuation of the fiscal year 25 grant agreement. And as you might recall from our meeting in April, we had planned for a fiscal year 26 grant program, but we were never able to put out that request for application because it did not get approved. So now we're operating under the fiscal year 25 one with modification. That through September 30th covered providing in-person assistance to Medicaid recipients, QHP recipients, and mixed households. Without that federal funding, the most that we can do with just state-only funds is covering the QHP work and covering the mixed household works, or families. So that's what is before you today, but you'll have more time to talk through, is that extension of the fiscal year 25 grant agreement. A couple things that I do want to mention is that the local health departments and the departments of social services are funded to provide in-person assistance to Medicaid recipients. Our application counselor sponsoring entity program, which we have in place, also does a lot of in-person Medicaid enrollment. So we do have other outlets, albeit it will be, obviously, as you heard from David, a big impact on the Connect Earning program. So that you'll be hearing in a little bit. One of the things that just by happenstance, I was listening this weekend to the Conduit Street podcast, which is put out by Mako. And they were interviewing Zachary Markovitz, who's a VP for Results for America, which is partnering or working with the governor's office on working towards having evidence-based grant-making process. And I had almost forgotten, Governor Moore's Enough Act program was really involved and hopped on board with Results for America. But I had forgotten that over a year ago, we hopped on board as well, we the Exchange, with Results for America. And actually, Mr. Markovitz mentioned us in the podcast, Maryland Health Benefit Exchange, as one of the agencies that really worked towards grant making, evidence-based grant making process. And that was all in that RFA for fiscal year 26. So we'll continue to carry that forward. But I did want to also highlight the good work that has been done around that as we move forward. So you'll hear more about that. Just on the federal updates, we are patiently waiting for Congress to do their thing on keeping government open and hopefully continuing funding for the expanded tax credit. The good news is the message has finally gotten to all levels that without continuing these tax credits, we will have significant premium rate increases and we will have significant loss of enrollments. So we're waiting to see, latest word on the street is that Senator Schumer is just kind of saying, this has to be in, whether it happens or not, who knows? We've been advocating, and we meaning actually as of a couple weeks ago, Marie Grant and Johanna and I went down and met with, or we videoed with the congressional delegation to really make sure everybody was aware of the impacts. So as I said, that message is getting through, but we are hopeful that it will happen sooner rather than later, because later in the cycle, if we get into November, December, will really cause havoc for keeping people enrolled and getting information out to them. The other federal update, there was the federal district court ruled on the City of Columbus versus Kennedy, and that was regarding the implementation of certain provisions of the final marketplace program integrity rule. So that turned out to be a good thing for us because some things are stayed while that's being litigated. And the biggest impact for our Maryland folks is there's a provision that if you did not file or file taxes and have your taxes reconciled with your APTC, the existing law was after 2 years, the exchange would have to stop providing those tax credits, which again would make coverage very unaffordable. It was reduced to 1 year. In this ruling, they questioned the 1 year, but also questioned whether even the 2-year bar was allowable under the way the law was written. So that has been stayed at this point. We will not be imposing any limitation on being able to provide tax credits. So that's a good thing for us. And we'll wait and see what happens with that in the long term. In terms of state updates, we do have on the agenda today, but we're gonna probably pull it unless I hear different from our insurance commissioner on the individual market rates. So I think we're still waiting to get final word on that. They will be published this week. We were hoping we could let the board know today, but we're not quite there yet. And Commissioner, if you want to add anything to that, please do.
Nothing has changed, Michelle. Yeah, we're not ready for an update today, but they will be coming out next week, and I'm sure or this week, and I'm sure we'll be talking more about them soon.
Okay, thank you. And then just finally, from an agency perspective, obviously we're all focused on open enrollment. We're focused on messaging around, again, what will happen with the expanded tax credits, the DACA, which we've already been communicating on that, but we'll continue to focus on communications. Our primary goal this year is retention, so that's what we're trying to do. And then we are in the midst of working on our fiscal year 27 budget, state budget, and as far as staffing goes, I think we're fully staffed right now. If not, they're all in the pipeline. We usually have them all ready to be filled. So I will stop there in the essence of time, and if there's no questions, we can move on in the agenda.
Great. Any questions for Michelle?
Ken here. Michelle, I'm a little bit confused about, could you go over again the details behind the CMS grant change between 25 and 26?
Ken, if I can have you wait till the presentation, because in the slide deck, there's information on that, and we'll be talking through that as we go through the agenda item.
Okay.
I guess just one question on another development was the expansion of people eligible for catastrophic plans in states that use the federal platform to consider applications. Maryland is one of 4 that doesn't. So is it sort of status quo for purposes of eligible for a catastrophic?
Yeah, thank you for bringing that up, Joanne. So that was another thing that came out, that you have to get an exemption to have a catastrophic plan, and part of the federal government, or what's coming out of CMS, is that they want to broaden that so anyone can get catastrophic, or more people can get a catastrophic plan. That impacts our reinsurance program. It impacts the population of the exchange. It impacts how risk adjustment is factored. And fortunately, we are only one of 4 states that elected to do that exemption processing on our own. which means we do not have to implement this at all, and we have chosen not to. We will not be implementing any extra exceptions for the catastrophic plan. Our bronze plan is very well priced, and it is, again, that option if you want a high deductible plan, and has very comprehensive coverage. So that's the choice that we have made on that.
Thanks. Glad to hear it.
Michelle, can I editorialize there for 2 seconds?
Do.
I think I saw some writing in a publication that framed it as an attempt to provide other options, and I think as you just reiterated, it's not a meaningful option for addressing the other issues facing affordability in this market.
Thank you. Okay, thanks.
All right. I think next we will turn to the policy committee report. And then after that, the standing advisory committee report.
Hi, thank you. Everybody can hear me okay?
Yes.
The board policy committee met on August 14th, shortly ahead of the August board meeting that was on the 18th. And the board attendees included myself, Joanne, and Commissioner Grant. Thank you. The staff briefed us on the 2026 proposed subsidy and reinsurance parameters, which was then presented to the full board the following week on the 18th. Johanna also briefed us on the proposal to delay implementation of the 1332 amendment pursuant to the Access to Act. So that's to allow Maryland residents to enroll on exchange regardless of immigration status. So that's on the agenda for today's board meeting for further discussion. And then lastly, Joanna updated us on implementation of the federal provisions from the Marketplace Program Integrity Rule and Reconciliation Bill that are going into effect this fall. Specifically, she spoke to effective August 31st. The exchange ended the monthly special enrollment period for people under 150% of the federal poverty level, as well as the 60-day extension to the baseline 90 days to resolve income inconsistencies. And then effective at the end of this month, the exchange is disenrolling the DACA individuals. Thank you.
Great, thank you. The standing advisory committee?
We are meeting this upcoming Thursday. The biggest news is we have a new co-chair, Stephanie Clapper, that is joining Mark in her role in his role. And so this week we have a few things on the agenda. We'll be discussing, let me just quickly situate us. Give me 1 second. Just want to make sure I don't miss anything for you all. So we'll be going over the final update on the 2026 state subsidy and reinsurance parameters, and we'll be discussing similar to what we're continuing to do today around the upcoming federal changes. And we'll talk a little bit about our marketing strategy for the 2026 open enrollment. But if there's anything that folks would like for me to carry forward for Thursday, feel free to let me know.
Great, any questions? Okay, next up is compliance, audit, and privacy annual report.
Yes, thank you. Scott Brennan, Director of Compliance, Audit, and Privacy. Thank you for the opportunity to present our annual compliance report. And as Cynthia pulls it up, I'll begin. Well, let's make sure we can pull it up actually on second thought. Cynthia, are you able to share?
I'm seeing it, but I'm guessing you're not.
No, we are not.
All right. So on behalf of the Compliance Department, I look forward to sharing important initiatives, key programmatic data points and metrics, as well as audit and internal review updates. Next slide, please.
Cynthia, can you put it in slideshow mode as well, please?
All right, so this report is broken down into 4 sections, and these include MHB policy updates and revision initiative, our fraud, waste, and abuse report. Third, our privacy program metrics, external audits, corrective actions, as well as internal reviews. And finally, the last section is our OLA, or Office of Legislative Affairs, audit, overview, and update. And by reference, the OLA report was circulated with the board materials, as well as a summary of our findings, the findings of OLA and our responses to those findings. So hopefully you're able to take a look at those and review them. I'll discuss them in detail closer to the end of the presentation. Next slide, please. Are you able to? Now I don't see the presentation. Cynthia,
Yeah, I'm sorry. I have it showing on slides. Michelle said she doesn't see it on slides, so I don't know what's going on here. It was just up a minute ago. I apologize.
Is it in the shared drive, Cynthia?
Well, yeah.
All right, I'll share it.
I also have it pulled up and can share it, Michelle, if that would be helpful. Oh, you're on it.
I said it's not loading for me quickly on my computer. So
To be honest, I think something's going on with Zoom because I got many people that emailed me and said they could not get on Zoom. So I'm seeing it on here just fine. I don't know. Let me try it again and then tell me.
Well, let's have Johanna try it and from her computer and see.
How's that working?
We can't see it. There we go. Perfect. Thank you. Okay. Thanks, Johanna.
Thank you, Johanna. And I think we're on slide. Yes, this slide. So the first section is MHB policy reviews, revisions, and updates. So at MHB, we put significant time and resources into ensuring that we have comprehensive, updated policies across the exchange. And compliance is responsible for this function. And to that end, we have a formal process established for policy creation as well as updating of policies. And this spans from scheduled policy reviews all the way through execution, internal publication, as well as dissemination within our agency. So as part of the policy review update initiative, we've updated 70 of our 81 policies this past fiscal year. So we're very proud of that accomplishment. We believe that that comports with what the tenets of a compliance program should. And this slide represents those policies that are in the advanced stages of review and update. So we're almost there, but again, very proud of our cross-departmental collaboration in getting all of these up to date and making sure that everyone is apprised of the requirements, both from a regulatory standpoint and legal standpoint. Next slide. Now, on to our fraud, waste, and abuse report. So there were, in fiscal 25, there were 11 fraud, waste, and abuse allegations, and these came in through the compliance hotline or other direct reporting means. Of the 11 complaints that were investigated as potential fraud, I'm going to back up and describe the categories. They fall into 3 categories, which is substantiated, unsubstantiated, or unable to substantiate. And if they were found to be substantiated, then an investigation found credible evidence existed to verify the substance of the allegations. The inverse is true for unsubstantiated. And if we were unable to substantiate, that means that we would require additional investigative tools to come to a conclusion. And oftentimes those additional tools would be provided by Maryland Department of Health. So that's just a little procedural background on how we classify. So of the 11, happy to say 9 were unsubstantiated and closed. 1 was substantiated and forwarded to MDH for further investigation. And 1 was unable to substantiate, and we forwarded that to MDH for further scrutiny. Moving on to our debarment and sanctions screening. This is something that we do very rigorously at the exchange. And this is running all vendors, all employees, and all contractors and carriers through the U.S. Health and Human Services Office of the Inspector General, list of excluded individuals and entities. And so we do this check prior to the start or engagement with any contracts, employees, or contractors. And we do it on an ongoing basis every month to check for any potential exclusions. So this just summarizes the scope of what we're checking. And we regularly check that and have for many years. Next slide, please. Okay, next is our privacy overview, and this really represents our privacy program metrics. I want to start at the bottom, pardon the overlap on some of the text there, but I want to start at the bottom half of the slide with our number of incidents. On the far left, you'll see the bar graph demonstrates that we had 195 incidents in fiscal 24. That has been reduced to 158. So that's always good to see that direction is trending in the right way. And then off to the right, you'll see 2 of our most prevalent types of privacy incidents. And these are misloads in the middle, and then unsecure emails by producers. And what these are basically, if a document is improperly loaded into HBX, then it is reported as a misload, or even if it has the potential to improperly share private personal information. And then unsecured emails by producers are often those emails that are sent in a non-encrypted manner that isn't consistent with the regulations we have surrounding protection of private information. So you'll see that these don't add up to the total number of incidents. We do have a garden variety of other incidents that occur, and we handle those in a timely manner. But this should give you an overview of the way that we believe we're trending in the right direction. But there are numerous variables that will affect this: number of producers, open enrollment, and so that trending does vary month by month and year to year. Now I'm going to go back up top. Part of what we do in our privacy program is we make sure that we have non-exchange entity agreements in place, or NEAs, with all of our affiliated vendors and our producers. And these basically govern data privacy and the obligations related there too, as well as privacy reporting protocols and requirements. On to our assessments, our privacy impact assessment, as well as our independent audit of MARS-E, which is minimal acceptable risk standards for exchanges. And these are required to be reviewed every year, which we do. around the March to June timeframe, and these were completed satisfactorily. Then finally, our trainings. We have annual compliance, privacy, fraud, waste, and abuse, and cybersecurity training that happens every year around April. Role-based trainings relate to specific subject matter areas to include federal tax information handling and other systems within our exchange. And finally, our consumer assistance worker training happens in October, right around open enrollment. And so these are annual trainings that are consistently improved and responsive to all of the updates that we face as an exchange. Next slide, please. All right. So our internal reviews, this is our internal reviews were paused last fiscal year, but they were resumed this year. And that was as a result of us focusing on Office of Legislative Audits. But this schedule basically shows you how the time frame during which and by which we completed these internal reviews. So basically, these are risk-based or corrective action-based looks into particular sections of these programs. And so we'll look at past audit findings and past risk ascertainment, and then we'll test and we'll look at policies as well, and we'll test various aspects of those. So we do that across the agency, and this is a less formal version of an internal audit. We call it internal review, but the standards are similar, and this is part of a consistent monitoring and an internal review process that again happens every year, and we're scheduled to tee that off again soon for this present fiscal year. Next slide, please. All right. Now, this slide summarizes our external audit timeline. We are heavily audited both by state agencies as well as at the federal level by CMS. And this is just a summary of the audits and the current status of those audits. So the first audit is IPTA, or improper payment pre-testing and assessment. And MHBE is part of cycle 1, which is roughly a 2-year audit cycle. And that began in January of 24 and concludes at the end of calendar 25. Then the MDH PERM audit relates to state and Medicaid payment integrity analysis, monitoring, and testing. That's ongoing. Our DBM RED audit is a recruitment audit that is conducted by the Department of Budget and Management, and that was completed for fiscal 25 and is kicking off now for 26. Then we have our security safeguard audit, which is conducted by the IRS. This relates to federal tax information and the enhanced protections that requires. And so they have very tight controls, and they test those controls rigorously. So this is a very substantial audit with our privacy department and our cybersecurity department. And then the next 3 audits are really kind of 3 in 1. The CMS SMART audit, that's the second to last item there, has 2 collateral components: the internal independent financial audit, and then the independent external programmatic audit. And what we do is we have an external auditor come in, perform that independent audit to test various controls under the ACA for financial and programmatic integrity. And then the results of those are submitted as part of our annual SMART submission to CMS. And then conclusions are based on the culmination of those submissions. And last but certainly not least is our Office of Legislative Audits. This report was completed in January of this year, again circulated with the board materials. I'm going to talk about that a little later in the next slide, so I'll move on. All right. And this is just a summary, quick summary of the findings and corrective actions that came out of our audits. Happy to report that out of our independent external audit that I described as part of our SMART audit for CMS, there were 0 findings for the financial side. There were 0 findings for the programmatic side. Our CMS SMART audit came clean with no findings, so we're very happy about that. Our Maryland Department of Budget and Management RED audit did have 4 findings. We have corrective action underway to make sure that we improve that year over year. So we take that very seriously. And again, that's proactive improvement. And we have processes in place to get to where we need to be. And then these next 2 are ongoing, the PERM audit with MDH as well as the IPTA, again, ongoing. And then the IRS safeguards has variable rolling. The IRS safeguards has variable rolling corrective actions that we work very closely with IT with to ensure that they are implemented in a timely manner. And then finally, our Maryland OLA audit had 6 findings, and the corrective action is largely complete, but in some instances is still underway. Next slide. All right, and then the last section of our report is the OLA audit overview and update. So this, for those not familiar with the Office of Legislative Audits, this audit happens once every 3 years. And this examination period was for the 3-year time frame from March 9, 2020 to June 30th, 2023. The actual audit began in 23 in June, and then actually concluded in January of 25. So a 17-month long audit. And this is by far the most intensive and resource focused of all our audits. We take it very seriously. And then this examination, it goes beyond just, it focuses mainly on financial controls and procurement activities, but it really does go well beyond that to enrollment activities and spans just about every department. And then, of course, how we adhere to our policies and federal and state regulations. Again, this was included in board materials for your review. Hopefully that summary table helped make it a little more digestible. Tried to break down that summary into the 6 findings, 3 of which were related to policy. One was related to consumer assistance, and then the final 2 were related to finance and procurement. And what we do is OLA will come out with the report. MHBE will publish or submit a formal response. And we go back and forth with OLA. Sometimes we agree with the findings, sometimes we don't. We memorialize that, we see where we can land, and then the culmination of that is the published report with not only the findings, but also our agreement or contention to those findings. And to that last bullet, MHBE maintains certain exceptions and disagreements with a number of findings. We're confident with the reasoning behind this, and we stand behind it. But I will say, in the spirit of acknowledging OLA's concerns and always trying to increase program integrity, we continue to work with OLA to try to achieve resolutions where it is practical or possible to do so. So currently working with MDH to see what we can do to address a lot of the concerns the limited concerns that OLA had regarding our activities. Next slide, please. All right, so I want to leave some time for any questions or comments at this point. All right, hearing none, I guess we can move on. Thank you.
Hello, can you hear
Sorry,
me?
I was on mute. Okay. Yes, okay, Johanna, it is your turn with the closing the loop on the state subsidy regulations.
Thank you. All right, this should be pretty straightforward. So we've been talking about the state subsidy program extensively in recent board meetings. As you all know, legislation establishing the exchange's authority to operate that program passed earlier this year. In May, the board approved submission of proposed regulatory language as well as emergency regulatory language. So we were pursuing a dual track because you can get the emergency reg in place more quickly because you can skip a couple of procedural steps. And so we proceeded with that because we wanted to make sure we had the language in place prior to open enrollment, but the emergency regulations can only be in place for a limited period of time. So in order to have the regulations kind of fully on the books, you need to go through the normal rulemaking process, which we were doing in parallel with publication of the regulations as proposed. So we are now ready to take those proposed regulations. They've been fully through the process and ask the board to approve them as final. As a refresher, these regulations cover the structure, implementation, and eligibility standards for the program. They're very similar to the regulations we already had in place for the Young Adult Subsidy Program, just a few modifications. They have been through a formal public comment period. We always do an informal public comment period prior to even proposing, the proposed regulations, so that we can try to incorporate and address any feedback prior to even bringing them to the board. Then they go through a formal public comment period after the board approves them as proposed. They've been through that. We just got one comment that generally offered support for the regulations and the program itself. So pretty straightforward. And now we are just asking the board to approve the regulations as final. And you should have had the text of the regulations in your board materials as well. Happy to take any questions.
Does anyone have any questions for Johanna? Okay, then if there aren't any questions, we'll do a vote on this. Can I have someone advance a motion to approve the final state subsidy regulations?
This is Kat. I'll make a motion to approve the final regulations as presented and authorize MHBE to submit them to the Division of State Documents for publication in the Maryland Register.
Thank you, Kat. Is there a second?
I will second that motion. Yvette.
Great. All those in favor?
Aye.
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 Okay, thank you. I have
Cynthia,
everyone.
did you? Great.
I do. Thank
Okay,
you.
so Johanna, back to you for the 1332 waiver.
Thank you. All right, so switching gears now to discuss an update on implementation of our 1332 waiver amendment. So some background on this topic. So we have our existing 1330, or we have long had a 1332 waiver since 2019 in place to support operation of the reinsurance program. And at a high level, the 1332 waiver allows you to waive certain provisions of the Affordable Care Act if approved by the federal government. So we've had that waiver in place for reinsurance. States only get one kind of 1332 waiver, and you can amend it to add additional things that you want to waive to that overall waiver. In 2024, the General Assembly passed the Access to Care Act, which directed the exchange to apply for an amendment to allow all residents to enroll on exchange regardless of immigration status under the Affordable Care Act, only citizens and legally present residents can enroll on exchange. So this would have allowed individuals with other immigration statuses also to enroll through the exchange. That waiver was approved on January 15th. And at that time, we informed in the federal government in our waiver application that we intended to launch the enrollment under this amendment in November for coverage starting January 2026. So with our open enrollment this year. However, due to federal developments over the last several months, we are asking the board to approve submission of an updated implementation plan to delay implementation of these changes to our eligibility until open enrollment for 2028 plans. So that would be in fall 2027 for January 1, 2028 coverage. Specifically here, the impetus for this is we did not foresee when we applied for the waiver the amount of work that would be coming to the exchange due to both the program integrity rule and in particular the reconciliation bill from this summer, which is going to have the exchange working intensively with MDH to implement many of the changes to Medicaid eligibility that go into effect in the fall of 2026, and then significantly work requirements effective January 1, 2027. So over the next year and a bit, we're going to be working intensely to stand that up. And that really is a resource load that we had not anticipated when we were initially planning to launch this program. So, and I think, yes, this slide largely addresses what I just shared. We are proposing in the letter to CMS to update our implementation timeline that we would implement earlier than the proposed date of January 1, 2028 if our resources allow. In that case, we would discuss that with the board and notify the federal government at least 6 months prior to our planned implementation date. When we do implement this, we do have to work with the feds to make some adjustments to the way that we report data to them as a result of this initiative. In order to make this update, because it has already been approved, the amendment has already been approved by the federal government, the terms of our waiver with the feds require us to hold a 30-day comment period to collect public feedback on these proposed changes. We launched that comment period already because we have been in conversations with our federal partners about their thinking on this front, and their advice was to get this started as soon as possible, given that January 1 is approaching. And so we haven't received any comments on this so far, but any we will certainly share back with the board and include in the, and we are required to include them in the materials we would submit to the federal government. This slide shows the original implementation plan that we had for the waiver, which I described previously, showing that launch of coverage for this population in January 26. To the right highlighted, you see the updated plan with that launch planned for January 2028. And so that's the topic, and happy to take any questions.
Thanks, Johanna. I might start. I just want to clarify that this will then enable this waiver to come in line with all of the implementation work that we're going to have to do for HR1, correct?
Sorry, could you say that one more time?
That this edit to the waiver implementation would just enable the waiver implementation to come in line and be aligned with all of the implementation work that we're doing, like with Do It around HR1 implementation.
Yes, it will allow us to kind of stagger. So this would come online a year after some of the heavy Medicaid work goes online.
And if there, God help us all, but if there are further changes to, you know, what we're allowed to do, et cetera, then it also gives us time to put that into place.
Yes, there have been, proposals at the federal level that would sort of functionally kind of prohibit the state really from moving
Right.
forward with this in any case. Those haven't passed, but we were monitoring them over the summer, and it was part of the reason that we were sort of holding on kind of
Right.
getting going with implementation earlier this year.
Right. Okay, that was my chair's prerogative to ask question. Do others have questions?
Joanne has her hand raised, and then Doug.
Doug was
Great.
first. I
Oh,
followed.
sorry.
I
Didn't see
followed.
that.
I didn't make it formal with a hand, but since you followed the rules, Doug, you should go first.
It's I don't much mind, but this is really helpful. Hearing you walk it through. Can you just say maybe a little bit more background on how individuals with a who are not U.S. citizens enroll in coverage today? And especially given all the changes with HR 1, I'm trying to understand what that will look like for them over the next few years.
Yeah. So non-citizens who are not legally present cannot enroll through the exchange, but they are able to enroll directly with an insurance carrier in the individual market off exchange. So nothing has changed about that ability for them to seek coverage off exchange. That was in existence and, you know, for now continues to be in existence. I haven't heard any proposals to change that. Individuals do have to pay full price for their coverage, so they're not eligible for any federal or state financial assistance. But that was also going to be the case when, if and when they enroll through the exchange, because included in the Access to Care Act, those individuals still were not going to be eligible for federal or state assistance. They would have been able to get the benefits of enrolling on exchange, of getting our consumer assistance, our easy to use platform. And for all those reasons, we felt that it was still valuable and worthwhile to offer the on exchange enrollment off coverage option. But at a baseline, those individuals can still find coverage off exchange. For individuals who are legally present non-citizens, they will be experiencing changes in their eligibility for federal financial assistance in different waves over the coming year but they will continue to be eligible to enroll on exchange. Their eligibility for federal premium tax credits and Medicaid may change over the coming year.
And Johanna, if I can just add to that, that anyone can go to Maryland Health Connection and use the get an estimate and get information and look at the plans and compare plans. So anybody is able to do that. Of course, they would not be able to enroll through the exchange.
Thank you. That's really helpful. Appreciate it.
Joanne?
Yeah. I understand the rationale behind this, and there was a lot to do on the Medicaid front, and I know, you know, in particular, preparing for people that will lose eligibility for Medicaid based on failure to meet the work requirements, and then if they get sent over to the exchange, it's going to get complicated, and there's a lot of work to do in that regard. I am concerned about taking what I believe is a binding vote prior to the close of the comment period. And I'm just wondering if you had any communication with the feds that you can share about whether or not they would have considered an expedited comment period. This is, you know, not really affecting any of the 4 guardrails you had to address in the application regarding federal implications for federal deficit because they're unsubsidized. And I'm wondering if there was any discussion with them about an expedited comment period so that we could be voting after the comment period closed, or, you know, how you're thinking of, you do have to, it looks like, to read that, I guess the section 8 of the terms and conditions that you flagged for us in the board materials would require a summary of the comments received in sending in this request for an amendment. Have you thought about those alternatives, either, you know, an expedited comment period or waiting till after the comment period closes before the board takes a binding vote?
So I CMS was pretty clear that they wanted and expected us to do the 30-day public comment period, but I think we could bring this back to the board in October if that was the board's wish for a vote in October. And we could communicate with CMS about kind of the timeline and process we were in.
I would appreciate that. I understand that you're up against a very tight timeline here with the November 1 OE, and that's when people were supposed to enroll. I am uncomfortable with opening something for public comment, taking a binding action, and then, people may still, it's a little more than a week into a 30-day comment period, and people may still submit comments, and it may or may not change the outcome here, but they would, without us revisiting it to at least hear what people had to say after today, it would feel, not fair to people who came in with their comments later.
I understand. I think if other board members share that sentiment, then we can certainly move this to the October board meeting for a follow-up vote.
I'm gonna just chime in and say, yeah, I agree with Joanne. I don't know if there are other operational considerations, want to be mindful certainly of the tight timeline MHBE is moving on, but I do think that if we have the opportunity to wait till post-comment period, it would be helpful.
I agree with Joanne as well.
Maybe just
Any other questions? Oh, go ahead.
I was just going to ask to that point, are there other operational considerations why you feel like this would need to happen today based on what others were saying is moving it to October? Okay.
Yeah, it's really been primarily driven by our federal partners' kind of desire to get this wrapped up. But I think, we can share our proposal and kind of where we are with the board and let them know that we'll be following up in October.
Okay. Yeah, thank you. That makes sense then to me.
Then do we need to make a motion to defer this? Or
Yeah.
I
we
don't
just don't make
think
any motion?
so. I think we can just move on and kind of put a pin on this to come back in October. But Christopher, anyone who can weigh in on the technicalities, please jump in.
Good afternoon, everyone. This is Christopher Randolph. I don't think you need to take any action if you're not going to bring it to a vote at this point.
Okay. Well, thank you everyone for the discussion. So I think, Commissioner Grant, we are skipping the market plan landscape, individual market plan landscape. Is that correct?
I think this is actually MHBE's team, Madam Secretary, and
Oh,
I think
okay.
this
So
is
this is a
fine.
different thing. This is not the rates. Okay.
Yeah.
Okay, then that's what we'll move to next.
Thank you. Yes, this Nicole Edge from our policy and plan management team will be presenting on the plan landscape from a high level in terms of carrier participation, number of plans that were filed with us, not getting into the details of the rates. Thank you. I'll turn it over to Nicole if you're on.
Yeah, I am on. Thank you, Johanna. We can go ahead and move to the first slide. Okay, so for plan year 2026, our carrier service area map has not changed at all. We did lose Aetna as a carrier, but that doesn't change the landscape of what coverage looks like for our three participating carriers, well, four participating carriers: CareFirst United, WellPoint, and Kaiser. CareFirst United and WellPoint continue to be our statewide service area, so they cover the entire state. Kaiser continues to be partial state. They don't cover the entire state. They're more of that central area with partial service areas still in Charles, Calvert, and Frederick counties. Next slide. So number of QHPs being offered for the upcoming plan year 2026. So again, Aetna exited the individual market, so they are no longer offering plans in Maryland or any other state individual market for that matter. So we did lose the 9 plans that Aetna offered. However, we do have some additional plans from Care First for their silver plan. And so they are offering 2 additional HMO silver plans and then an additional PPO silver plan. Other than that, all of the other carriers look to be the same from 2025 to 2026. So we will have a total of 43 plans, and that includes the 3 catastrophic plans that we have. And then Kaiser still continues to offer a platinum plan. Next slide. So for deductible, not much change again from 2025 up to plan year 2026. You will see again that addition of the Care First plans and the silver deductible for 2026. They did come in and offer an additional HMO silver plan, and that's entries a deductible of $2,500. And then their silver PPO, they have a $3,500 deductible plan that they are offering for 2026. And then all of the other carriers are pretty much remain the same, not much variance between 2025 and 2026 plan years. And again, for AV, not much variance there either, as Maryland looked to keep the AV the same for 2026 plan year from 2025 plan year. And then for our dental landscape, that remains the same. We have all of our participating carriers back offering the same number of plans that they had before. So we have both the PPO and the HMO networks available on exchange. Low tier and high tier, and those counts continue to be the same. So in total, we have 11 plans being offered on exchange, and all of those dental plans are available statewide. Any questions for the upcoming plan year, what the plan landscape looks like? All right, thanks, Johanna.
I don't have a question, but I do want to say how pleased I am. I think this predates me, but that the exchange did not allow for the broader variation in actuarial value that was under the program integrity rule that is now in litigation. You know, it's much better for consumers, and I appreciate the foresight and wisdom of the exchange, you know, being ahead of I think every other state in that regard. Others are still scrambling and wondering what that might mean for their OE. So I really appreciate that position that the exchange took.
Thank you. And that's another benefit of being a state-based marketplace where we can make those decisions, and it was deferred to the states to make the decision. So thank you for that.
All right, thank you.
Okay, so if there are no other questions, then we'll move on to the connector entity, which Michelle, I think you spoke about a little bit at the beginning.
Hello, everyone. My name is Tamara Gunter, and I'm the Director of Consumer Assistance. Today, I'm humbly coming to you to ask for an extension for a grant request fiscal year 2026 through October the 1st, 2025 through June the 30th, 2026. When initially established, the Connector Entity Program had a clear mission to promote outreach, education, and enrollment in qualified health plans. Over time, however, the program adapted to meet the increasing need of Maryland residents, especially those at or below federal poverty level, by providing assistance with Medicaid enrollment. This expansion, though not a part of the original plan, was motivated by compassion and the needs of our communities to ensure every Marylander had access to health care through the no wrong door approach. And what is the no wrong door approach? That means wherever you went, any state agency as far as offering Medicaid, whether it was a connector entity, the call center, local health department, or DHS, we would be able to assist you with getting a health plan, whether it's through Medicaid or QHP. Thank you. Slide 1. The original CE grant request period ended on June 30th, 2025. The board previously approved a 3-month extension, and that was from July the 1st through September the 30th to ensure continuity of the CE operations while CMS reviewed the Medicaid funding approval. Current request, MHBE requests that the board approve an additional 9-month extension for the CE grants, and that will take us from October the 1st, 2025 through June the 30th, 2026. With this extension, this will uninterrupt CE operations during open enrollment 13 and through the remainder of the current fiscal year. As the federal Medicaid funding has not been approved, the extension will support assistance and provide private pay and mixed household consumers only the duration of the state fiscal year. Next slide, please. I'm going to read this verbatim because this is very important on the timeline. The timeline for the CE grants, March 2025, MHBE was notified that there was some requirement changes to federal funding request match dollars for the CE program. And with this said, that there are now 2 initiating 60-day periods that was implemented. October 2025, the board approved a 3-month extension for the grantees. In April, that same month, MHBE requested application, the RFA was submitted to MDH for CMS approval. May through July, there was a lot of discussion being held back and forth with CMS, MDH, and MHBE regarding the grant process because this process was new to everybody. The grants had never had to send the RFA over to CMS for prior approval prior to this year. August 2025, MHBE was notified that there was going to be a hold on the RFA review process. CMS requested additional information at that time. July, okay, next slide, please. Thank you. The outreach data target. So our outreach target in the meta areas and neighborhood census tracks and identifies through the U.S. Census data as having high concentrated areas of uninsured individuals. Community prioritization use demographic and social economic indicators to focus on communities with historically low enrollment rates and to meet their needs. Navigator staffing. They have adjusted their staffing at levels according to the demands and forecasts, particularly during peak open enrollment and high traffic area locations. Mobile navigators deploy navigator teams in rural areas and unserved areas to expand coverage and access to healthcare. Slide 4, please. Thank you. Partnership in-person enrollment events. They build substantial relationships and organizations, representation, industries less likely to employ or have sponsored covered insurance. Work jointly to advertise and conduct enrollment events during and beyond open enrollment periods. Brand their signage. This makes sure that they clearly mark the home sites and partners and helping people get assistance. Apply constant branding across the locations and foster great relationships with the community. Next slide, please. Engage in a wide range of community events across the counties, such as health fairs, school functions, job fairs, and local festivals. Given the priority to this diverse crowd, we like to maximize the visibility of outreach throughout the area. Next slide, please. So these right here are the areas that we cover. So there's no area left behind. We cover all of the counties. The CEs do great work. They have representation through all of the counties in Maryland. Next slide, please. So the Connector Award and modification through October the 1st, 2025 through June the 30th, 2026. I'm not going to read this verbatim, but here is the allocations of what we gave for the budget extension for 7/1/25 through September, and what's left in the budget now for state funds, which is $2.5 million. Next slide, please. I know we have some questions, and I have some other things prepared for you for my questions. So is there any questions about this extension period? Anything else you may need on Medicaid data?
I would appreciate, I don't know, I could use more information about the Medicaid component of this. It sounds like from your presentation, this is the first time that these grants have been submitted, have had to be submitted to CMS for approval. It sounds like prior to this, you could just blend Medicaid funding with state funding for the conductor entities doing marketplace or mixed households or, Medicaid. So can you just help me understand what the process, how the Medicaid stream plays in here and what's different about this year with the grants that I think is effectively removing the Medicaid funding from what is available to the connector entities. Is that right?
Yeah, so prior to this year, we had a different person that was at CMS. And basically, the requirements that we're being asked for now were not the requirements we had been asked to prior. So prior to this year, prior to March, we never had, you're correct, we never had to submit a different proposal for the CE federal match funding for the CE program. This is the first year we've ever had to do this. We definitely, everything was submitted timely. It's just that, this is a new process, and it's new not to just MDH, but it's new to everybody. It's also new to CMS. There are, the Navigator program or CE program prior and the federal exchanges, they've all been cut, right? So with our program, again, we've never had to do this type of procedure before. So this is all new. So that is what's taking the delays.
And if I can add a little bit to that, I don't want to get things confused. So there was for the Affordable Care Act on the QHP side, the federal government did allocate funding for navigators. Federal government on that side has eliminated that funding. So that's a kind of a separate issue. And for the Medicaid work, as Tamara said, over time, we have provided more and more in-person support for Medicaid recipients. We have not had to submit any pre-review, pre-grant or pre-RFP review process through CMS. That was something new that started for the exchange last year. And now everything that involves Medicaid funding has to go first through MDH, and then MDH sends it to CMS. So the timeline has been extended to get that approval. And that's why we ran out of time on this one, because it's not approved and we're already at the point where that funding is going to cease. And I see Johanna and Tony came on camera, so you might want to add something additional to that.
Yeah, just a little bit more kind of backstory, Joanne, in response to your question. So we did traditionally submit, we did include the Navigator program in our annual submission advanced planning document, which is the kind of document that we submit to, we kind of work with MDH and submit to CMS annually that describes our activities for Medicaid for the upcoming year and the amount of federal funds that we're requesting to support those activities. So that was traditionally included, submitted, approved by CMS. But what's new now is this requirement that we submit our RFP or RFA ahead of time to get its approval. To get the approval both of the RFP or RFA before we release it, and then CMS requires approval of the award determination before we publicize the awards. So that is the piece that's kind of catching us up now. And in addition, like an additional layer here is we had the fact that this is an RFA and a grant program instead of an RFP was an additional kind of source of something that was a little out of the ordinary and required more conversation to figure out how to proceed.
Yeah, I'm sorry.
Go ahead.
But the only thing I was going to add is the requirement to submit to and get approval from CMS is for those procurements and grants that are in excess of 500,000. So, yeah, so it's above 500,000 that we have to do that. I'm
So
sorry.
one thing that wasn't shown on the slides is how much of a decrease this funding is compared to prior open enrollment years for the connector entities. I don't have a sense of, Eastern Shore, we're looking at $200,000 for the next 9 months, but how much funding did they have last year and previous years? Or how much of a cut is this?
This is definitely a significant cut.
That we
Are we talking like a 50% cut? I just have
Well, it's about a 50% cut. So I think
yeah.
And have the
I would-
connector entities, like, I imagine you've been having conversations with them. Have they said like how this cut is going to impact their operations and ability to carry out their functions?
We've definitely had conversations. This will definitely affect their ability to carry out operations for Medicaid. Not for not for I'm sorry.
So I mean, it's a no wrong door, right? So
Yes,
how
no
are
wrong-
they supposed to is the expectation that they're supposed to pre-screen people and then not have an appointment with them? Or
Sorry.
if they're out at a community event and then in the process, they find out that the person actually is eligible for Medicaid and then they stop there and tell them to go away. I mean, how is that even possible to
Right.
police that?
So we have at least 4 of our CE programs are actually health departments and a DHS office. So they have federal funding and the staff there to handle this caseload. So we're not sending anybody away. They will still be seen, these individuals will still be seen and handled accordingly and to ensure that everyone has access to healthcare.
And the other component, and it's a very good question, Kat, on that, because again, once we started providing more services to Medicaid and we submitted for funding of Medicaid, the Medicaid funding, I think it's about 60-40 split or 50-50 split because the exchange picks up the state match for Medicaid as well. But we do have other sources for Medicaid recipients, as Tamara said, the local health departments, departments of social services, our application counselor programs. They all provide enrollment assistance for in-person enrollment assistance for Medicaid recipients. Of course, the call center is available for any other Medicaid recipients. So we're going to have to really look at how we can service folks outside of the Navigator program, of Navigator and the Connector Entity program. It will be a large hit on the Navigator program, which will be likely mostly in staffing, as they'll need less staff to do enrollments. And I'm hopeful that if there's any, as many of them are embedded already in LHDs or DSS offices, that there may be opportunity there to roll over into a position there. The other item that we are looking at is twofold. One, there's the request here for the continuation of the grant with state funds because this grant ends September 30th. So we need to do something quickly to make sure that the programs still have funds coming in beyond September 30th, and we have state funding for it. So that's the request for this approval, strictly using state funds between now and the end of the year. We are not able to have the board pre-commit any federal funds. And as we've been told, if we do that, we risk losing all federal funds. So that's why we can't deal with the federal funds. However, we will be working with our MDH colleagues to ask CMS to, under this existing grant, which is the fiscal year 25 grant, to recognize or do an extension of this grant and provide federal funding under this this extension. And then at the same time, being put forward the fiscal year 27 request for application with plenty of time for CMS to get that approval done. So this is the best alternative we could come up with at this moment in time to keep the program afloat with the funds we have until we can get commitment from CMS on federal funding.
Thank you for that, Michelle. I was just about to go over that. And also, I do have all of the RFAs ready to go, so there will be no delays. I have everything at my fingertips just to submit. It's just submitting it and getting the information over to CMS and giving CMS their time frame to approve it. And even though we send over to CMS, like I said, there's 2 60-day time frame period. Just want to make sure we understand that. So once we do that and they approve it, once we do solicitation, get the grantees, we have to send it back to them with the grantees information and the amounts again. So this is a process. Just want to make sure everyone understands that.
Thank you. Thank you both for that additional detail.
No problem. Thank you for the question.
Would you mind just going back to the slide, though, that has the different connector entities and tell us which ones are embedded with departments of health, where it sounds like there's some backup
Sure.
still with constrained resources, but
yeah, sure.
On their own, and how that might work to Kat's question about in those specific CEs if they're not embedded with the Department of Health or something.
Yes. So the Eastern Shore is also embedded with the health departments. We have, the Lower Shore, we have HCAM. Prince George's County is a local DHS office. Montgomery County is a local health department.
So that leaves, I'm sorry, I was trying to take notes. You were faster than
No problem, no problem.
So that leaves, who is out there?
That leaves, I'm going to say, AHAC West, Far West. And I think, if I'm not mistaken, I believe they also have a direct contact with local health department. They're just not affiliated as far as a grant, but they also have affiliation with the health department and ACs in that area also. Also, I want to say that we're doing a work group. We have our first session and a meeting on September the 22nd. And this is to go over best case practices and how we can, I know it's not a lot, but we can take this $2.5 million and maximize MHBE's, maximize the staffing and the different things they would need to actually pull off this open enrollment. It's definitely going to be difficult. It's MHBE's, I could say MHBE definitely didn't want to see this happen, but this is where we are now. So our first meeting is September the 22nd.
And that's 2.5 million, Tamara, right?
Yes, 2.5 million, yes.
And is there anything you can say about, it is a very different year, lots of information out there, mixed messages, and I think you said the priority will be retention. It looks like the basis for allocation here is uninsured. How are you thinking about this very different OE and the possibility that some people might, the state subsidy with the regs just approved is immensely helpful, but there's probably a lot of mixed messages. How are you thinking?
So with with qualified health plans, it's always supposed to be the practice that CEs enrolled and then they actually did a warm handoff to a broker, and the broker maintained a relationship with the QHP moving forward. Then we have the mixed households. We do have brokers who also handle mixed households also. And again, the CEs, the intent of the CE program is to get new enrollments. It's not existing enrollment, so that will be their focus, is to focus on new enrollments. Existing enrollments will be going to the brokers for qualified health plans, the local DSS offices, and health departments when it comes to Medicaid. So it's pivoting. It's definitely going to be a change for this year, but it's basically just pivoting, making sure that once you get the enrollment and you get the person enrolled, that those entities actually have a relationship with the other party. And then we also have application counselors who can actually sit side by side. We have over 50 entities now, over 250 application counselors throughout the state of Maryland who are eager to help individuals also get enrolled. But with the application counselor program, they actually do in-person assistance only. They have to sit down with the consumer. They don't have access to the worker portal. They can sit down, the customer logs in, and they work through that customer's application with them side by side. So we will be making sure that we have a list of AC programs, brokers in the area that will be given out to the CE programs. We're going to be, like I said, all hands on deck to make sure that our CE programs have all of the tools they need for this very difficult open enrollment.
And I was going to just mention also call centers available too.
Yes, of course, the call center is always available.
Ken has his hand up.
Michelle, or this question really, Tamara, in your community outreach and engagement strategy, how this is such a dramatic and transformational component for the CEs, how are we collaborating them to ease in this handoff, I guess is the best way to describe it, to the brokers? Because it seems like that's it's changing their whole business model, and they are a business.
Yeah, so that was always supposed to be the practice. That part didn't change. The CEs were supposed to enroll into QHP and do a warm handoff to a broker. That's not new. That's the existing policy, procedures, and practices. So that should already be embedded into their program.
And just to add to that, Ken, different connector entities have done it a little differently. I know I think it was Montgomery County or Prince George's County, they used to have like a rotating group of like three different brokers that would attend events with them. And so different connectors have used different processes. And as Tamara said, in our monthly meetings, we'll start looking at how to make those more effective, how we have the broker connect vehicle, which is on the phone. Do we need to, have that where that could be that handoff? I don't know. We still have to figure that out. But again, the intent is, Tamara said, the intent of the program has always been to go find the uninsured, right? And bring the uninsured in and get them enrolled as step one. And then moving on to getting those to brokers who can then take over that. Likewise for our call center. We want those people to get connected with a broker so that what we find is, and that's why we do the bat phone transfer through the call center, because what we find is when somebody's connected to a broker, year after year after year, they go to their broker, which frees up resources at the call center, frees up resources at the connector entities to go out and find the uninsured, which is what our intent is.
Yeah, I get that, Michelle, but if you go back to the original legislation, it was incumbent on one of the tenets of the legislation to assist individuals in public programs. And I think the connector entities do that in support of the mandate for addressing social determinants of health. My concern is if we're going to hand this off to brokers, are we going to still keep within those dictates of the original law?
Well, we have been doing that for, 12 years.
Yes.
I mean, that's why there is a broker operations program and why, I mean, that's built into the ACA as well, the utilization of the broker program.
Okay.
I don't have any other questions, and I know we need to act on this, and it's, you know, that's just the way things are, the situation we are in. I did want to make a comment though that this way of presenting the uninsured by percent of uninsured in the state is a little bit misleading, or can affect people's perception, because it makes it look like the lower Eastern Shore has a very low uninsurance rate, where in fact those counties, especially Somerset County, might have a higher uninsured rate than other counties and need more resources to move the needle on there. So it makes it look like we don't have that many uninsured, but the percent of population that's uninsured can be anywhere from 4 to 8% in those counties. So I just wanted to make that statement that this is one way of looking at this, and I understand y'all are doing this to justify the differences in amounts of funding being allocated, but I just wanted to call that out as a representative of the shore.
And I'll just suggest, as the chair of the policy committee of the board, this would be a great deep dive item for the policy committee to look at. We can get information on it, and perhaps there is a better way.
Great, thanks.
And
Thank
Marie had her
you.
hand up.
Yeah, thanks, Michelle. I've just been listening to the discussion here, and I think this is one of the things that like allocation might be a difference discussion, but having to take this overall decision, unfortunately, it sounds like a decision we're in. This is not something the exchange has funds to backfill in your fiscal year 2026 budget. I guess that's a question to confirm.
That is correct.
That's correct. Any other questions?
Less of a question, just more of a comment. It was similar to what Kat kind of brought up. I was just thinking about particularly who the individuals are that are going to be uninsured, and kind of just thinking of the delineation of the percentages. Like, is it going to be heavily like a subset of a population? We were earlier talking about immigrant populations. We were talking about just more broadly across social determinants of health. The disparities in those counties may look much more heavier by like particular race or particular ethnicity. And so I just wanted to bring that into the conversation, just to continue to, as we talk about opportunities to bridge folks into being insured, just keeping in context that folks could be further exacerbated just given with some of just where we are right now.
Thank you. Yeah, I agree.
And I'll just add, just to wrap up a discussion point, Kat, we could, with the policy committee and then subsequent to the whole board, I think the other thing we should do is, as part of this discussion, is show the results that Tamara and her team have worked on with Results for America on the outcomes-based, how to do grant programs, looking at outcomes-based. And so, again, there may be ways to modify how we're doing this, to modify the funding structure, but I think that would be a good discussion that we could have initially with the policy committee and then with the board as a whole.
Yeah, that would be great. I did try to slice and dice some of the data y'all have on your website, but I kept breaking it. So maybe put those requests in instead of just using what's available to the public.
Yeah, and I also I can also send you just a spreadsheet to show you the enrollments in the different areas, if that's helpful. To show you, you know, where the enrollments are going at and who's getting what enrollments, if that helps. Any other questions?
Aika, is your hand up?
It is an old hand. I will drop it. Thank you.
Well, I appreciate this discussion. I think all of us are, dealing with the challenges of the current environment that we're in. And I think, some of what you all are raising about like how we look at the data to determine when we do have these challenging situations to make sure that we are deploying our resources in the most effective way towards the goal of, getting people covered. I do think that we have to advance a motion here on whether the board approves this modification and extension for the period of 9 months to the current connector entity QHP only grant agreements. Do I have someone to advance the motion?
So moved.
I'll second.
Okay. Okay. All those in favor?
Aye.
Okay, thank you.
Thank you, everyone. I appreciate your time today.
Thank you. I think the last item, since the rates is the one that came at for 345 that we're not doing right now. The last item is on the Amazon Web Services contract extension. So Venkat, I'll turn it over to you.
Thank you, Madam Secretary, members of the board, and everybody. Today, I will be joined by our procurement manager, Tracy Campbell, as well. I'll give a brief outline about this product and how we are using it within the exchange, and hand it off to our procurement manager to go through the procurement process and the request. So the Amazon Web Services infrastructure, the AWS infrastructure, there are two AWS that Exchange uses. One is the MD Think, formerly MD Think, currently MD Benefits Platforms AWS Services, which hosts our production environment, our consumer portal, worker portal, etc., the production environment that the customers log in, our staff log in, etc. And this is another AWS platform that the Exchange hosts, and over the years, increasingly, we have migrated several environments and also built newer tools and other products into our Exchange that connects with other systems and other agencies, etc. So, for instance, in the last year, we have built a disaster recovery portal, which is a significant improvement from what we had before, and with CMS approval, and we have built a capability for the Exchange to operate in case something terribly happens to the MD Benefits program or otherwise. And we also migrated 10 of the lower environments that were hosted on the MD Think platform, formerly MD Think platform, into MHBE's fold to integrate tightly with our applications and bring more efficiency into our processes. And also in the last, because of these migrations, we were able to definitely see some cost shift from MD Think program to what MHBE is hosting this AWS platform. Not only cost shift, kind of dollar to dollar, but also we were able to save some costs as an overall ecosystem of AWS infrastructure. And on top of these initiatives, we have our stakeholder site hosted on the MHBE's AWS platform, and our recently implemented MHC Small Business Portal is also built on this program. We have been very successful with our Broker Connect applications, also hosted on this platform. And since last year, we have implemented Live Agent Chat on this platform. We have received more than 400,000 consumer requests through the chat. It's a very significant product for the Exchange as well. And last year, at the end of the open enrollment, and this year we are expanding this product. This is the AI agent for call center for consumers to automatically get some service automatically through an AI agent for technical requests such as password reset, which kind of paid for itself already, so to speak, in terms of software costs and the cost to build this application as well. This is also hosted on the AWS infrastructure. Again, more applications like our internal staff site and also the increasing presence on the Tableau dashboard. I think can you briefly refer to the data that look at our website. So that's also hosted on this platform. And we're also more into automating our processes and removing redundancies, eliminating a lot of manual processes through RPA, the robotic process automation. The servers of these products are also hosted on this AWS platform. So this is in the last 3 years, if you look at the presence of the various applications on this platform that have significantly improved. And we are requesting the board for a contract extension of this particular AWS subscription. With that introduction, I'll hand it over to Tracy.
Good afternoon. My name is Tracy Gamble. Thank you, Venkat. As Venkat stated, we had a contract currently in place that went in place November 1st, 2022 to October 31st, 2024. And then we exercised a 1-year option last year, which started November 1st, 2024, and will end October 31st of this year. And we actually awarded this contract as an ICPA, and we did a request for quote through the GSA Schedule 70, and the awarded vendor or current vendor is A&T Systems, Inc. On September 16th, 2024, the board approved to exercise option year 1, as I stated, in the amount of $1.5 million with a federal participation amount of $990,000 and a state participation amount of $510,000. Next slide. Based upon current CMS requirements, we are required to actually acquire CMS approval prior to pre-solicitation of a new contract. And currently, MHBE's contract value does exceed $500,000, necessitating CMS approval for that particular contract. The current AWS draft solicitation is with MDH for review for CMS submission, and it has been there since May of 2025. Now, with limited possibility of CMS approval prior to October 31st, hence that's the reason we're coming to the board to request a 6-month, extension from November 1st, 2025 to April 30th, 2026, while seeking approval from CMS. Next slide. This is basically a breakdown of the federal and state participation amounts, which is 66% federal amount of $660,000 and a state participation amount of $340,000 for a total cost of $1 million. Next slide. Are there any questions?
Any questions for Venkat and Tracy?
I'll just add, this is Michelle, and I'll just add that this is another situation where we've had to get an extension because of the timeline involved in getting things CMS approved. So this is a little trickier, and we're having discussions internally because obviously if we can't fund AWS, we can't operate. So we're talking internally about, can we slice this contract and pull out state only, and how would that work so that we're not in this position? But this is another result of that process that's in place.
Yes.
Okay, so if there aren't any questions, MHBE. I'm sorry.
Oh, go ahead.
MHBE requests the board's approval on two items. One, the approval of a 6-month extension from November 1st, 2025 to April 30th, 2026 of the Amazon Web Services subscription from A&T Systems, Inc. to ensure continuous operations of the exchange systems while CMS approves the new procurement. And then the second item is to approve a not to exceed amount of $1 million for the extension period, with the federal participation amount of $660,000 and a state participation amount of $340,000. pending CMS approval for the contract extension.
Thank you for summarizing that. So if there are no further questions, do I have a motion?
So moved.
Second.
Great. All those in favor?
Aye.
Good night.
Okay, thank you all.
Great. I think with that, Michelle, I can turn it back to you for any closing remarks.
Well, thank you all very much, and thank you for the really good discussion today. We really appreciate that. I think we have some action items that we can follow up on with the board, and again, we will keep you updated on progress as we make it for additional funding for the Connector Entity Program. So thank you all, and thanks for your time. Have a great afternoon.
Thank you.
Thanks, everyone.
Yeah.
Bye.
Bye.